Welcome to the 21 IWBNC. My name is Esteban Ramirez. I am a second-year neurosurgery resident. Today I'm going to talk to you about a case of a focal extranodal primary polymorph hemangioendothelioma treated with endovascular embolization plus resection surgery. I have no conflict of interest to disclose. Hemangioendothelioma is a rare vascular tumor that was first described in 1982. It is a tumor with a biological borderline behavior as an intermediary pathology between benign hemangioma and malignant angiosarcoma. Also, it can be divided in different subtypes relying on the cellular features. These subtypes are epithelioid, papillary, retiform, caposiform, pseudomyogenic, composite, and polymorph. This later being the rarest variant. The first case of polymorph hemangioendothelioma was described in 1982 in an analysis of 39 patients of primary vascular lymph nodes tumor, where 3 of them were described as PH. Until 1999, 6 patients have been described. Up to date, less than 10 cases of properly called PH can be found in the literature, most of them from the lymph nodes, and a rare case from maxillary soft tissue. Given the small number of cases found, the natural history of the disease has not been elucidated. The utility of previous endovascular embolization followed by open resection has not been described in the context of a vascular malignancy with high bleeding rate during open surgery. A male patient between 20 and 30 years old presented to the outpatient clinic due to a lump in his dorsal back that has been increasing in size in the previous 6 months. He didn't report any weight loss, fever, or neurological deficit. 2 months ago, the patient had consulted previously to a different hospital where an open biopsy was performed but presented a significant blood loss and the procedure was suspended. The histopathology result described a lesion comparable with hemangioma. Since then, the patient had noted a significant size increase. The patient had no other medical conditions and no medication use. Physical examination showed a dorsal T10 cm mass, non-mobile, slightly painful, with no erythema or secretion associated. The rest of the examination was unremarkable. The patient recovered without complication and was discharged 24 hours later. Spinal digital subtraction angiography is shown in this slide, showing an arterial supply through T10 and T11 radiculomedullary arteries, being the black arrow and the red arrow, respectively. Embolization of the T10 radiculomedullary artery was performed, shown by the black arrow, and the T11 radiculomedullary artery embolization wasn't performed because the multiple branches visualized and remained permeable. This is shown in the red arrow. En bloc resection of the dorsal specimen was achieved, as you can see in the first image. The 3D tumor border mass was confirmed by histology, and angiomatous areas composed of ovoid, polygonal, and spinal cells with low mitotic activity was documented. The PH natural history, rate of recurrence, and potential to metastasize is not well known given the limited available literature. Likewise, the first-line treatment has not been standardized, but total resection is recommended. Additionally, immunotherapy and radiotherapy has been proposed as adjuvant treatment. Given the vascular etiology of the PH, operative bleeding can be of concern and should be addressed. This case was approached with preoperative arteriography that revealed arterial supply from radicular T10 left artery, and in the absence of Adamkiewicz artery, coil embolization was indicated and could be performed without complication. Afterwards, open surgical resection was performed with low operative bleeding and complete resection with tumor-free edge specimen. This is the first case of extranodal primary PH treated with endovascular coiling plus open resection and show exceptional results. Thus, this is an approach that should be taken into account. Extranodal polymorph hemangioendothelioma is a rare type of tumor whose treatment has not been elucidated. It can be treated with endovascular embolization followed by open resection to achieve complete excision and lower complication rates associated to bleeding. More case reports are required to elucidate the natural history of this pathology. Thank you very much.